Okay, let's go ahead and start. Today, we're going to talk about blunt thoracic trauma and how we want to think about the management of our patients. So let's go ahead and next slide, please. Okay, first case, you got a 25-year. Sorry. Can you mute, please? Thank you. A 25-year-old female involved in a road traffic accident complains of severe chest pain, difficulty breathing, shortness of breath. And as soon as you start hearing the story, what are you already thinking? I'm thinking rib fractures. I'm already thinking that this patient, and by the way, the younger the patient is, the greater the force is required to break ribs. Please understand that. So when you're looking at patients, age becomes a very important consideration in your thought process. Sagar, you had a question. You have your hand raised. Okay, I guess not.
No, sir. No, sir.
Okay. Yeah. You said your hand raised on the thing, so that's why. Okay. All right. Let's continue down the road. Physical examination reveals bilateral chest wall tenderness. Now, here's the other rule about chest injuries. You can have rib fractures without radiographic evidence on your chest X-ray. Chest X-rays don't always pick up radiographic evidence of rib fractures. If the patient is showing tenderness, if you're pressing on the chest, typically if you press on somebody's chest and they're wincing or they're hurting, you got a broken rib. There is no question about it. So please remember that. And you can document it as clinical rib fracture. You may not have a radiographic evidence, but you're still documenting clinical rib fracture. That is very important, okay? And you have CREPS. The CREPS tell you that you have pulmonary contusion. And remember, pulmonary contusion, when you have it on one side, this is clearly shown by multiple studies on this, is that once you have it on one side, it is transferred through the blood to the other side as well. So what happens is by 24 to 48 hours, if you're hearing CREPS on one side, it's not surprising that you're hearing CREPS on the other side as well. The patient didn't aspirate. This is just the pulmonary contusion hemodynamics, if you will, and the pulmonary dynamics that are changing. So that's what you need to be looking at. So BP is 160 by 90, heart rate is 110, probably related to pain. Respiratory rate is 30, the SpO2 is 90% on non-rebreather mask. Okay, so remember also this, once you go on positive pressure ventilation, NIV does not help you in these situations, does not. It does not confer any real benefit. Unlike COPD patients and heart failure patients, in trauma patients, NIV does not confer any real benefit. So if you're going to move to positive pressure ventilation, intubate the patient. Take care of the patient that way, and you will gain a little bit more of an advantage as far as time and pulmonary reserve. Next slide. Okay. Now, here's the other thing to remember about where the area of tenderness is. Now, remember in trauma, we always think about associated injuries, right? So if I have tenderness in the ribs in the upper part of the chest, then I have a situation where ribs 1 through 3 may have fractures. If ribs 1 through 3 have fractures, the associated injury with that is great vessels. So I have to be thinking about the great vessels in this area anatomically. If I have ribs 4 through 6 broken, in that area, I'm thinking about pulmonary injury. If I have lower than that, I'm thinking about intra-abdominal injury. So, again, blunt injury is very important to be thinking about. Now, the other thing that you also have to think about in the chest is blunt aortic injury. Now, remember, blunt aortic injury typically takes place when you have severe deceleration or acceleration, deceleration type injury. That is, if you're, let's say, a patient fell from a height or was involved in a road traffic accident where they were moving at a certain speed. Remember, if they hit a stationary object, if I'm moving 30 miles an hour, I hit a stationary object, the closing speed is whatever my speed was. If I hit a moving object coming in the other direction, then my closing speed is actually whatever the speed that object was moving at and my speed. For example, if a bus is moving 30 miles per hour in one direction and a scooter is moving at 30 miles an hour in the opposite direction and the scooter hits the bus, the effective force is as though the scooter was traveling 60 miles per hour. The closing speed is 60 miles per hour. So remember that, because that gives you an index of suspicion regarding blunt aortic injury. So you have to be thinking about the presence of blunt aortic injury. Now, the most common location, and you get this question all the time on different board examinations, the most common location for aortic injury is at the aortic root. But those patients are all dead. By the time you see them, they're dead. They're dead at the scene. But the ones that survive, it's at the ligamentum arteriosum. Now, when it's at the ligamentum arteriosum, what happens is these injuries are tamponaded. That is, you will not see hypotension related to that aortic injury. You will have aortic injury. It is an urgent issue that you have to deal with. It is not emergent. Emergent means if I don't do something within the next few minutes, the patient will be dead. If it's tamponaded, it's not going to kill the patient within the next few minutes. What I need to think about, if the patient is tachycardic, tachypneic, hypotensive, I have to be thinking about cavitary bleeding, not tamponaded bleeding. So please remember that. Next slide. Now, obviously, motor vehicle crashes, road traffic accidents are the most common cause, right? And again, risk factors include speed, the lack of seat belt, lack of helmet on the part of two-wheelers, right? All things that we see routinely. The difference between India and the United States and other countries, India and other countries and the United States, is in the United States, you have trauma being managed by surgeons. In India, the intensivists are managing trauma. We are managing trauma as intensivists. We are, that role does not go to the surgeon. Now that means we have to call the surgeon in for specific issues. So again, something to keep in mind. And by the way, people always ask the question, do I need a cardiothoracic surgeon to help manage thoracic trauma? And the answer is no. Most cases of thoracic trauma injury can be managed simply by putting in an ICD, which can be placed by either an intensivist or a general surgeon. It does not need a cardiothoracic surgeon. The number of times you need to go to cardiopulmonary bypass or something like that is very minimal. And thoracotomy, the role is very minimal. Having managed a lot of these patients, so the need for cardiothoracic surgery is absolutely minimal. And you don't need cardiothoracic surgeon in your hospital to help manage trauma. Not necessary. If you have them, great. If you don't have them, it doesn't mean that you can't handle the trauma. Okay. The next thing is you want to make sure that you make note of how many rib fractures you do have. So as you go down the ribs, you press down, and as you're pressing down, you're going to count the number of times the patient winces. If the patient is wincing all the time, then obviously they have a bunch more broken ribs. So you make notation of it. Now, again, if you have more than 3 broken ribs in an elderly patient, the mortality is up to 25%. So be careful when you're dealing with patients over age 60. Watch your numbers, okay? Because if you have rib fractures and more than 3 of them, or more than 3 areas where the patient is really tender, you better be thinking this patient absolutely positively needs ICU, absolutely positively needs a close eye, because the mortality risk is over 25%. Next slide. So blunt aortic injury, let's go through that. Again, Most blunt aortic injury patients die immediately at the scene, not an issue. But those who survive, we need to think about how we're doing it. And endovascular repairs have really come into play. So really speaking, we've gotten better. And again, if the patient is over age 60, very high risk for aortic injury. If they were in the front seat of a car, very high risk for injury. Non-seat belt use, very high risk for injury. Remember also, if they suffered traumatic brain injury, the probability that they also suffered thoracic injury is very high. Again, these patients, anytime you're seeing these kind of patients, I want you to think along those lines. Next slide. Okay. And again, pulmonary injury is very common with both blunt aortic and cardiac injury. So you can see this. And again, pneumothorax, very common. Now, please, if you're doing an evaluation in the ER, you're looking at the patient, you're doing your focused abdominal sonogram for trauma with extension, and you're not seeing lung sliding, put the chest tube in. Okay, if you suspect pneumothorax, I'm not saying confirm, I'm saying suspect, put the chest tube. Because if you wait, the consequences are very grave, because if you wait, the patient, it can turn into a tension pneumothorax and the patient will be dead before you get the chest tube in. So get the needle decompression in, put the chest tube in, and then get a chest x-ray. Do not wait. And we've all seen these x-rays where there's a big tension pneumothorax and the mediastinum is shifted over. That was a process error by the team that was managing the patient, because that patient should have already gotten a chest tube and needle decompression, chest tube, and then an x-ray. Getting an x-ray at that point is, in the beginning is not helpful. You don't need to confirm, just put the chest tube in, get it taken care of. Now, again, pulmonary contusion, especially in younger people, if you have ribs that are broken, remember the amount of force required to break a rib in a young person is quite significant. And that force is not limited to the rib. Guess what? It goes straight through to the lung. So you're going to get injury to the lung. So that injury to the lung is called a contusion, right? It's a bruising of the lung, right? Pulmonary contusion. So I'm more concerned not about the rib fractures, because the rib fractures are going to be there. The flail chest and all that, yeah, you got rib fractures. That's not an issue. The pulmonary contusion, however, is a significant issue. And the concept in the old days was, if you had rib fractures, that you bind the chest. Wrong. Then the reason for that is, if you bind the chest, your ability of your patient to take a deep breath is severely limited. If your patient cannot take deep breaths, the incidence of pneumonia setting in becomes much greater. So we do not bind the chest. Please do not bind the chest. That's an antiquated process, and we do not do it. We do not recommend it. Not for flail chest, not for any broken ribs. Do not bind the chest. If you bind the chest, you're going to give more pneumonia and more problem for the patient. What you need to do is pain control. Pain control is the key. Now, if you want to control the best way to control pain, by the way, is to put a thoracic epidural. Now, a thoracic epidural is placed by your anesthesiologist. If your anesthesiologist, most anesthesiologists, however, are uncomfortable in the face of severe trauma to place a thoracic epidural. So because of that, you may have to give intravenous or patient-controlled analgesia, pump opiates, and control the pain that way. You may have to do that. But if you can get your anesthesiologist to place a thoracic epidural, then you'll get much better pain control, and the patient will do a lot better. And by the way, the thoracic epidural works best when the patient is not intubated and when you have better control. Now, if the patient has to be intubated, the benefit of the thoracic epidural goes down. So keep that in the back of your mind. Now, the other thing that you have to do when you're looking at these patients is, after pain control, am I able to ventilate and oxygenate the patient? If I'm unable to ventilate and oxygenate the patient on a ventilator, positive pressure ventilation, then the flail chest may indeed be doing something as far as causing problem as far as ventilating and oxygenating. In that setting, you want to make an argument for rib fixation, I don't have a problem. The data is strongest where you cannot ventilate and oxygenate a patient related to the flail chest in that setting. Now, if you're able to ventilate and oxygenate without having any issue, then repairing the ribs does not help you. Again, the data is crystal clear on this. So please understand, I mean, if I'm a surgeon, we love doing procedures, okay? The fact that, it's available, it doesn't mean, that's the thing we want to do. Now, remember, I'm going to quote a famous cardiac surgeon that I had met very early in my career. His name was Denton Cooley. He worked out of Houston. Very famous guy. And he would tell me, he would say it when we met. He said, because I asked him about this, and he said, "Son, I can make love in a canoe, but why would I want to?" So it's very important to think about it that way. Just because we can do a procedure does not mean that the procedure is beneficial in any way to the patient. So you have to make sure, if you're going to do a procedure, is there indication, is there benefit? If there is no indication or there is no benefit, then subjecting someone to a procedure doesn't make any sense. Next slide. Okay, so again, more rib fractures, the greater the severity of injury, and multiple rib fractures, especially in the upper ribs, you got to think about great vessel injury. Mid ribs, you're thinking about pulmonary injury. Lower ribs, you're thinking about intra-abdominal injury. And again, if you have 1 or 2 broken ribs in a patient that's older, let's say over age 60 to 65, that patient population has to be watched very closely. If I have a young patient, let's say a 25-year-old, that has a couple of broken ribs, I'm not so worried. I don't need to put that patient in the ICU. However, if that same patient is over 65 with 2 or 3 broken ribs, that patient needs to be observed in the ICU. This is the issue that you have to keep talking about. And yeah, Shashi.
AKELLA, is the 65 applicable even for Indian subpopulation? Or do you
I
think
would
less
say it's probably even lower. It's probably, that number is probably lower. I mean, this data is out of Europe and America. That number is probably lower. Probably you want to start doing it at age 50, is stick them in the ICU and watch them, because the problem is the physiology is very intense. And here's the other thing about the physiology. By the way, even if they're not COPD patients, they behave like COPD patients. So what I typically do in all these patients is reduce the work of breathing by working on the bronchodilation. Yes, do I hear wheezing all the time? No. But if I can reduce the work of breathing by removing the bronchospastic component, even if it's minimal and I don't hear wheezing, it's okay. Go ahead and start it, because these patients typically behave like COPD patients, and you have to address the bronchospastic aspect so that you minimize the work of breathing. Again, work of breathing is the thing that we have to focus in on. And here's the other thing that I emphasize to everyone. Anytime you have a trauma, guess what? You're going to have a metabolic acidosis. Now, metabolic acidosis increases the work of breathing. People forget this. Oh, we have a metabolic acidosis. Do I have to treat with bicarb or not? No, you don't have to treat with bicarb, but you have to keep in mind that the work of breathing is up. So if the work of breathing is up, if I have an intubated patient, I can't extubate the patient if they have a metabolic acidosis going on. Why? Because their work of breathing is going to be elevated and it's going to be problematic for me to deal with. So this is the thing that I want you guys to remember. Focus on the work of breathing. And by the way, the ABG may be completely normal. Okay, you may be looking at an ABG and say, oh, that looks completely normal, I don't have to worry. Yes, you do, because your eyeball test is the best test. You're looking at a patient, they're working at breathing. Guess what? You need to focus on that patient. You can't just let it go. ABG is an adjunct study, not your primary. Your eyeballs are your primary. And by the way, do I need to listen? The input from listening using auscultation is about 10%. Most of what you're doing is you're observing and looking at the patient and looking how they're breathing. What are they able to speak? When they're speaking to someone, are they short of breath? Are they doing it in short bursts instead of normal talking? So these are the things that you're watching for. And again, good observation, and which we can do through a camera, is the way to go. Next slide. Okay, so the initial evaluation, again, airway, breathing, circulation, right? So again, the caveat is that breathing takes priority over airway oftentimes, right? If you're watching a patient, look at their breathing pattern. Are they breathing rapidly? Are they breathing shallow? Are they breathing deep? Are they Kussmauling? What's going on? So keep an eye on how they're breathing. And again, if they're in respiratory distress, again, needle decompress, think about tension pneumothorax, don't wait. I can't tell you the number of times people waited and the patient arrested. No, don't do that. And by the way, in a trauma patient, if they're already arrested and they're showing PEA, pulseless electrical activity, in that patient population, think about a pneumothorax because it could be there, and make sure you put in the needle decompression and put in the ICD. Think about it that way. If it's a trauma patient, think about tension pneumothorax. If the patient is already arrested, decompress that chest, decompress both chests, and then move on. You lose nothing. The patient may save, you may save a life. So think about that. Next slide. Okay, so again, if they're showing marked respiratory distress, and again, NIV in this setting is temporizing only until you get the patient intubated. Okay, please understand, do not leave the patient on NIV. This is not a good idea. Okay, either intubate or extubate, but do not leave the patient on NIV. That's not a good idea. And again, rapid sequence intubation is the way to go. If the patient is hypotensive because they have such a significant metabolic acidosis, consider using ketamine. Don't use etomidate, use ketamine. Ketamine is a wonderful drug. It's great for this kind of situation. By the way, it's also great for burns. But, for other types of situations where, you don't want that hypotension related to intubation, that's a great drug to use. Ketamine is terrific. Use it. Next slide. Okay. Assess your oxygenation and ventilation. By the way, how are you going to check out your ventilation? Well, end-tidal CO2 if you have it. But the problem, unfortunately, is as the patient evolves, end-tidal CO2 becomes problematic. Why? Because you'll get a gradient. As you get into ARDS situation, which is very common in trauma, as you get into ARDS situation, what will happen is the end-tidal CO2 will remain low, but your PaCO2 will climb. The gradient between the PaCO2 and the end-tidal CO2 will widen. So that becomes a real problem. So you can't use end-tidal CO2. Guess what? I have to get blood gases. So my suggestion is, okay, if you're dealing with trauma patients, as you're bringing them into the ICU, number one, get your baseline ABG. And please, doctors, I know, and nurses, as you're thinking about the finances of this, bundle it into your admission cost for the ICU so that you can get that initial ABG right off the bat. Don't wait till morning. If the patient came in the middle of the night, don't wait till morning. Get it immediate so that you know where you stand. Okay, do not wait. And again, patients will manifest with tachypnea, chest pain, hypoxia. Again, diminished breath sound. Diminished breath sounds is your biggest tip off. Now, the other thing that you need to look at is, now a lot of these patients with blunt trauma will have a collar on their neck. Take down the collar and have a look at those veins. Are the veins up? If the veins are up, they will look like tree trunks. They will not, there'll be no hesitation here. Okay. If you think they're not, there's no jugular venous distension, okay, no problem. Then it's hemorrhagic shock until proven otherwise. But if you have jugular venous distension in a trauma patient, you got to think about two things: tension pneumothorax or cardiac tamponade. Think about it. So again, make sure that you're thinking through this. And if you suspect a tension pneumothorax, you got diminished breath sounds, don't hesitate, don't wait. Immediately put a needle in second or third intercostal space, mid-clavicular line, and then fourth or fifth intercostal space, anterior to mid-axillary line, put a chest tube. Don't wait. The longer you wait, the more closer to death the patient comes. And again, I'm going to quote Dr. Denton Cooley on this. People used to ask him, how come you are so fast in the operating room? And he used to tell people, listen, anesthesia is, but this is the closest the patient will be to death in their life. So I want to be as quick as possible so I can get them out. Again, these are little things that, that stick in your mind that say, you got to work quickly. This is not about, we have hours and hours. We don't. Golden hour, absolutely true issue. Okay, next slide. Okay, so again, assess for signs of shock. Palpate your pulses. Now remember, when you're palpating your pulses, if you feel a radial pulse, that's 70 systolic, 80 systolic, right? About that. If you're feeling a femoral pulse, that's about 65, 70 systolic. If you're feeling a carotid pulse, you're talking about 60 systolic. So when you're documenting, when you're asking through the tele-ICU, you're asking your bedside colleagues, what is the pressure? Oh, we can't seem to get a pressure. Well, have them check. Radial, 80 systolic, femoral, 70 systolic, carotid, 60 systolic. Do you feel these pulses? Which pulses are you feeling? So just walk right down the list, and that way it's easy. Okay. And again, ATLS principles are very good, not only for how we do things, but also how we communicate. So when you're asking about a trauma patient, you ask, how's the airway? How's breathing? Okay. How's the circulation? What's going on with the disability issues, mental status and all that, right? Do they have traumatic brain injury and all that? But you notice one thing, whether they have chest injury or brain injury, I'm still going through airway, breathing, circulation, all the way down to disability. So my GCS doesn't come into play until I get to D. So please keep that in mind. Okay, next slide. Okay, emergency ultrasound is performed as part of your C. So make sure that you have your focused abdominal sonogram for trauma ready to go in the ER. Okay, in the ER, in the trauma bay. Okay, and the other thing about point of care ultrasound is the focused abdominal sonogram for trauma needs to be repeated. Please understand, the first time you do it, it may be negative. Second time you do it, it may be positive. So you have to repeat EFAST again and again as the patient remains in the ER. I don't want just one reading. I want multiple readings to be able to confirm whether the patient is actively bleeding or not. And by the way, if the patient is actively bleeding, the other thing that you will notice is the tachycardia does not remit. And please, when you see tachycardia, okay, don't tell me it's traumatic brain injury, because traumatic brain injury, we're supposed to see hypertension, bradycardia, not tachycardia. If I see tachycardia, I've got cavitary bleeding until proven otherwise, and I have to think, where is the patient bleeding? Are they bleeding in the chest? Are they bleeding in the belly? Are they bleeding in the pelvis? Are they bleeding in the thigh? Or did they bleed in the street? Where are they bleeding? Tell me. Okay. And I want that thought process going through your guys' mind. as you're looking at the patient, I want you to think about it, and I want you to be able to tell me, hey, I think this is what's going on. Okay, good. That means you've thought about it. And again, please understand, every member of the team, nursing, docs, CCAs, everybody has to think about this. Okay, I don't want just the docs to think about it. I want everyone thinking, so that, and I want that active discussion to be going on. Now, obviously, as if you're in the middle of the firefight and you want to wait a couple of minutes to, but if you feel it's important, shout it out. Say, hey, this guy may have a tension pneumothorax. Okay, good. And if anybody mentions tension pneumothorax, well, you know what the first thing that needs is needle, then chest tube, then x-ray, then discussion. Okay, please understand, do not wait and discuss. If you suspect tension pneumothorax, that chest tube needs to go in. No discussion, no issue. And by the way, I always get this question. After the needle is placed, I don't hear a hissing sound. Do I need to get a chest x-ray? No. Put your chest tube, then get your chest x-ray. Do not wait. Okay. Next slide. Okay. Again, emergency department thoracotomy. Blunt trauma, we don't do emergency department thoracotomy because there is no real benefit. Okay. Cracking somebody's chest exposes all the patients and all the docs and all the nurses to all that blood going everywhere. Don't do it. Okay. I don't care if you have a cardiac surgeon there. Don't crack the chest. It's not necessary in blunt trauma. Blunt trauma, if they're out, they're done. Okay. You do chest compressions, you do your CPR as usual. And if they get ROSC, God bless. If they don't get ROSC, fine. But you do not want to expose the team to that. Next slide. Okay. Secondary survey. Now, you need to assess for associated injuries. Okay. If I have lower rib fractures, the first thing that should be going through your mind is, do I have a ruptured spleen or a ruptured liver? Okay. You're going to have to make sure that you assess for that. Think about associated injuries. Trauma is all about index of suspicion for associated injuries. Do not let it go. Okay. And by the way, mechanism of injury is extremely important. Also, when the patient is coming into the ER, if you can talk with whoever's bringing the patient, what was seen at the scene, what happened, how did it happen, what was the mechanism, is all important issues in deciding where you're going to go looking for injury. So it's very important. Next slide. Again, mechanism of injury. Again, and normal vital signs do not rule out aortic injury. Remember, we said tamponaded structures do not always cause hypotension or tachycardia. So you're going to need your adjuncts. You're going to need your chest x-ray. And we're going to look at that. Next slide. Okay. Diagnostic testing, plain chest x-ray, right? You want to get a plain chest x-ray, ECG to rule out potential blunt heart injury. And again, if you have tachycardia, even sinus tachycardia, most common thing that we see, right? If you have sinus tachycardia, you need to get the next test as far as ruling out blunt heart injury, which is cardiac enzymes and an echo. You need to get it. Next slide. Okay, so the Nexus chest criteria are, if your patient, if your patient is over age 60, rapid deceleration, all these things, you need to get a chest x-ray or chest CT. Okay, so you need to think about it. Do I have indication to get a chest CT? I know people just randomly say, oh, I want to get a chest CT because the patient suffered chest injury. Don't routinely get it. It's not indicated. And again, every time you're getting a chest CT, you're giving it with contrast. The contrast is going to cause kidney injury, 10%. Okay. So anytime you're giving contrast to these patients, 10% incidence of contrast related injury is going to be sustained by your patient population. Remember that. It's not a free lunch. Okay, please understand that. Even if I own the CT scan, it's not a free lunch. Okay, there is a price to be paid, not just by the patient, but by the patient's physiology. So keep that in mind. And by the way, the treatment for contrast related injury is to bolus the patient with fluid before and after the contrast so that they do not become hypovolemic. There's this urban myth out there that, oh, you can give them mannitol or something else to flush out the kidneys. No, it does not help. It's a hypovolemia related issue. Bolus the patient with fluid if you want to do that. Okay, so very important. Next slide. Okay, so again, we kind of put the nexus criteria for you. But again, basically what it says is if you're able to visualize the injuries on chest X-ray, you do not need a CT. If you are unable to visualize, then certainly chest CT is indicated. Now, here's the other thing about trauma that is not the case with other issues as far as X-ray is concerned. If you see any pleural fluid, the assumption is that pleural fluid is blood. So what do I need to do? I need to drain the blood because it's going to entrap the lung. So make sure that anytime you suspect pleural fluid or blood in the pleural space, as far as a road traffic accident patient is concerned, you need to put an ICD. All these patients need ICDs. Okay, make sure you evacuate that blood. That blood needs to be evacuated. Absolutely, positively, no hesitation on that. Okay, please, because once you leave the blood in there, will it resorb? Yes, but it'll trap the lung. You'll get scarring in the pleural space and you will trap the lung and you'll have more complications. So if you have blood in the pleural space or fluid in the pleural space in a trauma patient, put a chest tube, please. Okay, next slide. Okay, now again, diagnostic assessment. Again, you notice the specificity, that is the identification of injury. We think CT identifies everything. It doesn't. Okay, if the CT is positive for injury, the specificity of identifying the injury is only about 20% in chest CT. Okay, now the negative predictive value, that is if the chest CT is normal, do I have any injury? I can tell you with 99% probability that there is no injury. So again, the negative predictive issue is very important. Positive predictive issue is also very important. So again, the fact that you found a little something on chest CT does not mean you've identified all the injuries. Please remember that. Next slide. Okay. And again, mechanism of injury. If it is a deceleration injury, think about what you're seeing. And again, this is part of your evaluation. Make sure that you have a high index of suspicion. Next slide. Okay. And again, if you have concerning chest findings, get a chest CT. And again, the diagnostic accuracy is far greater if it's negative. Again, that's the important thing to realize. Okay, next slide. Now, specific aortic injuries, again, CT scan with IV contrast is most common modality. And again, it can exclude blunt aortic injury with nearly 100% of the time. So if there is nothing seen on chest CT with contrast, you probably don't have aortic injury there. Next slide. Now, how do we manage blunt aortic injury? If you do have injury, bring your heart rate down, bring your systolic BP down. You don't need a BP of 140/80. You need a BP systolic of 100. Even in head injured patients, keep the systolic BP right around 100 so that you can control the situation and you don't get out of hand. And again, esmolol is a very useful choice to keep the heart rate down. If you need to use other antihypertensives, use them, but bring it down that way. Next slide. Now, you notice this is the chest x-ray of a trauma patient, okay? Notice that wide mediastinum. Look at that mediastinum. It's big and wide. What does that tell you? Possible aortic injury, okay? So again, you got to be thinking what's going on. Now, again, the chest tube is in. You put the chest tube in on that side. The other side, you've got contusions and everything. Watch this patient closely. Very important. Next slide. Again, blunt cardiac injury is also something that we have to think about, right? Next slide. Again, ECG is the most important thing that you're going to obtain. And again, pulmonary injury, here's the thing. Major pulmonary injuries include pneumothorax, hemothorax, pulmonary contusion. Again, here's the other thing to remember. If I have a lot of blood in the pleural cavity, okay, and it's still coming. Let's say I have over 1,000 ml in the initial insertion of the chest tube. Now, here's the thing to remember. If I have a lot of blood, it didn't come from the lung. The lung is a low pressure system. It didn't come from the lung. Where did it come from? In the intercostal blood vessels. That's probably where it came from. Now, if it slows down, I don't have a problem. If it doesn't slow down, then I got to think, what am I going to do? Do I need a thoracotomy? Do I need a general surgeon or a thoracic surgeon to go in and fix that? And also, do I need to transfuse the patient? Now, here's the situation in India. If you, again, blood components are wonderful, nice, but if you have whole blood, give whole blood. Do not wait. Do not hesitate. Give whole blood. Oh, we have only whole blood. Hey, that's the best thing you can give. You know, you don't need to give components, because if you give components, as you give more components, you're going to have to give FFP, you're going to have to give platelets, you're going to have to give cryo. Whole blood has all this. So give whole blood. It's not a problem. In the US and European Union, we have difficulty getting whole blood. So we have to give a ton of components. But here, whole blood is more readily available. Give whole blood. That's the best thing to do. So again, something to think about. Antibiotics. Okay. Once you put a chest tube, I think a lot of people do give antibiotics. But if you're going to give antibiotics, first generation cephalosporins are more than sufficient. You do not need to give meropenem, please. Okay. Do not give the higher escalated antibiotics. Not necessary, because if you give that, by the time the patient develops an infection, and they will, okay, over 50% of these people with pulmonary contusion will develop a pneumonia. When they do develop a pneumonia, if they're already on big gun antibiotics, guess what? You're going to have a multi-drug resistant organism that's going to grow up. So you're going to be dealing with having to treat that multi-drug resistant organism, and you're not going to have anything to play with in the bin. So think about that. So please do not use meropenem or piptaz for your first antibiotic in trauma patients. Use some cephalosporin, whatever cephalosporin you like. Okay, ceftriaxone, cefepime, even you can use Magnex, cefoperazone, sulbactam, but I wouldn't even use that, because that's a bigger gun antibiotic than you really need. Really speaking, first generation cephalosporin is more than enough. Next slide. Hemothorax. Anytime you see fluid in the pleural space, your costophrenic angle is blunted, put a chest tube. Put a chest tube and drain out that blood. Do not leave it. Okay? Please drain it out. Next slide. So here you have a pleural issue, right? You notice the haziness. This is a pleural issue. Drain it out. Okay? Put a chest tube. Get it drained out. Okay? Very important. Think about it. Okay? Next slide. Again, bruised lung. Remember, pulmonary contusions are just like pneumonias in the sense that they take time to develop. So what you sorry. Sorry. Are we back? I think we're back. Okay. Sorry about that
Yeah.
internet issue. Okay. All right. So let's continue on. Again, if the pulmonary contusion, if oxygenation and ventilation are being adversely affected, and how do I know about ventilation? PaCO2, pH. Look at that blood gas. Do not let it go. And by the way, I don't want people to look at a blood gas and give me an interpretation. I want you to read off the blood gas to each other. Do not give interpretation. Oh, we have a metabolic acidosis with some compensation. That tells you nothing. Okay, please understand. Okay, as doctors, when you're communicating to one another, to the nursing team, read off the blood gas. Let everybody understand what the numbers are, and they have to be able to interpret the numbers, because hey, as experienced as I am, I may misinterpret a number. And giving my interpretation only confuses the picture. So better to put down the blood gas and then put my interpretation, so that everyone is clear on what we're dealing with. And again, we don't need to prophylactically intubate anybody. Do not prophylactic. Oh, the patient has a pulmonary contusion, we need to intubate. No. Okay. The patient has a pulmonary contusion, we need NIV. No. Again, nothing prophylactic. Okay. If they can deep breathe and cough, actually, that's the best thing for them. Okay. Negative pressure ventilation, being able to deep breathe and cough out secretions, absolute best thing. So again, please keep that in mind. Okay. And again, pain control is the most important thing. No chest binders, please. No chest binders. Okay. Because that's going to limit the patient's ability to take a deep breath and cough. So very important. Okay. Next slide. And here you have pulmonary contusion, right? On the chest CT, you can see that there's a pulmonary contusion. Next slide. Okay. Now, tracheobronchial tree injury. Now, once you put that chest tube in, you're having continuous air leak. Okay. Now, remember, when you have a chest tube in, you're looking for three things. Is the column of liquid moving back and forth with each breath? That is called tidalling, Tidalling. That means that your chest tube is patent. Okay. So are you seeing tidalling? Second, are you having an air leak in the water seal chamber? Is air leaking out through the water seal chamber? If air is leaking out, that means you have a hole in the lung that is pulling air out into the pleural space, and it's going from the pleural space out through the chest tube into that into your chest, the container that you're using. Okay. Third, how much is draining from your chest tube is something you want to know on a regular basis. So our nurses have to be trained to evaluate for those three things when we have a ICD in. So make sure that you are discussing that with your nursing staff. Very important, because they need to be telling you that. Because if you're not getting titling, the movement of that water column, that means the chest tube is not fully functional and it needs to be removed or replaced. Very important, okay? Or both, so I mean, you got to think about that. So again, something to think in terms of, okay? So again, very important. Next slide. Now, the other interesting thing here is blunt diaphragmatic injury. Now, here's the thing that we always see in these patients. It'll look like on chest CT, you'll get a chest CT, and it'll look like a loculated pleural effusion. If a radiologist reads a loculated pleural effusion, that is a diaphragm injury until proven otherwise. Remember that rule, okay? Because nobody gets a loculated pleural effusion on the first go. So even if you put in a chest tube, they don't loculate the pleural effusion right off the bat. So if they've done that, and this is a trauma patient, guess what? You've got a ruptured diaphragm. Now, an easy tell of the ruptured diaphragm, what's the problem with the ruptured diaphragm? So what? The diaphragm is ruptured, right? On the left side, what happens? Well, you have pulmonary pressures that are negative, intra-abdominal pressures that are positive. You're going to suck intra-abdominal contents into the chest. That's the problem. So that's why all diaphragmatic injuries need surgical repair. So, if your surgeon is saying, so what, we don't need, yes, you need to operate, and you need to fix it. Can I approach it through the abdomen? Yes. Can you approach it through the chest? Yes. So your choice, but you need to get it done. It needs to be done. So very important. Okay. Next slide. On the right side, by the way, if you have diaphragmatic injury, it's not a big deal. But on the left side, you can see clearly there's a diaphragmatic injury. It needs to be fixed. Next slide. What about sternal fractures and so forth? Broken sternum, yeah, it's important. I'm going to have heart issues that I'm going to have to deal with, but the broken sternum itself is more a pain control issue, nothing else. Associated injuries are very important to think about. Always think associated injury. So if I have a broken sternum is a very thick bone. If it took that much force to break that sternum, imagine how much force is inflicted on the rest of the chest. Think about that. And that's how I want you guys to think. If you have scapular fractures, you have rib fractures, you have flail chest, think about how much force it took to break it and how much force is being impacted on the lung and the heart and the soft tissues inside the chest cavity. Think about that, because that is where the battle will be won or lost, not with the ribs or the outside. Okay, so very important. Okay, but pain control becomes a huge thing. So you're going to have to be thinking about pain control. Next slide. Next slide, Kartik. Next slide, or Mohammed. Next slide. Okay, so in summary, right, mechanism of injury, very important. If you are seeing a road traffic accident patient, think about chest injury, okay? And if you're examining them, put your hand on their hand, not an X-ray, not an ultrasound probe, hand on their chest, press down. Most people, if you press on my chest, I won't wince. If I have a broken rib, I am not going to let you keep touching me in that same spot. Okay, so if they're wincing, guess what? They've got broken ribs. Document clinical broken ribs. Document it. Okay, and then think about what else is broken inside. Okay, so again, airway, breathing, circulation. Again, breathing is extremely important, and that can be observed through the camera, by the way. You can watch how the patient is breathing. Look at the pattern. Okay, Are they breathing fast? Are they breathing slow? Are they breathing deep? Are they breathing normal? What are they breathing? How are they breathing? What are you looking at? Next slide. EFAST. That's extended focused abdominal sonogram for trauma. And remember, it needs to be repeated. It cannot be done just once. It needs to be repeated again and again and again. Okay. And I can tell you personal experience. I've had many patients where we initially had nothing in the pericardial area. Everything was clean on the initial one. Then we repeated the fast, and all of a sudden we had cardiac tamponade, and we had to get it drained out. We had to get it taken care of. So again, repeat examination, repeat evaluation. Like any trauma patient, please reevaluate the patient. If you're not sure what's going on with the physiology, re-look at that patient, go through the numbers, go through the details. The devil is always in the details. Okay. And if they're tachycardic or tachypneic, don't just leave it. Okay. And for those of you that are using radar, if the number is in pink, that means danger. Pink, danger. Okay. Those vital signs, look at those vital signs. If it's pink, that should be telling you, hey, look over here. The patient's not doing well. Okay. Look over here. The patient's not doing well. That is a single most important takeaway that you can take. Look at those vital signs. Do not let go. Okay. And make sure that you're addressing it. Okay. And again, decision not to image is a tricky one. If there's any doubt, image, get your imaging. Okay. Next slide. Chest X-ray, chest CT, we've gone through the logistics and all that. If the patient is not stable, here's the other rule. If the patient is not stable, do not go to Scanlan. Do not go to CT, because if you take them to CT, they will arrest. Murphy's Law, right? Murphy says anything that can go wrong will go wrong. Okay. And trust me, in CAT scan land, everything goes wrong. Oh, but we have a code cart in Scanlan. No, you're not going to be able to revive the patient. Don't leave the emergency department until you're sure that the patient is hemodynamically stable. If the patient is hemodynamically stable, yes. If the patient is not hemodynamically stable, do not move out of the trauma bay. Okay, next slide. And by the way, I do not mean bay in the terms of the derogatory term. I mean, the area is called a trauma BAY, bay. So you have to be watchful of terminology. Okay, so again, cardiac injury, think about cardiac contusion. Think about pulmonary contusion. Think about blunt aortic injury. These are the things you want to be focused in on. These are the things that will kill your patient. That which can hurt my patient is most concern to me. Next slide. Any questions? I know I went relatively fast. You can tell I'm very passionate about trauma. This is an area that, I think people need to be watching closely. And by the way, Cloudphysician is now introducing ER consultations. Please make use of them. If you're at a partner hospital, please make use of our ER consultation. Please make sure that you have an intensivist or a specialist looking at this thing and saying, hey, if this patient needs to be in the ICU, let's put them in the ICU. If the patient needs certain therapeutic interventions, have our people have a look. And I really want all our partner hospitals, please, time is of the essence. Time in trauma saves lives. Time is the biggest ally or enemy that we have. Dr. Ramurthy, how are you?
I'm fine, Dr. Chandrasekhar. Very nice presentation indeed. Thank you. I maybe missed some of your presentation. The rib fracture, when do you refer them for, the fixation of the ribs for flail?
Absolutely. I mean, unless you're having difficulty ventilating and oxygenating, the data on rib fixation is very biased, if you will. I mean, the studies that are there are extremely biased. If you're having difficulty oxygenating and ventilating, then in that setting, sending them to the OT to get their ribs fixed is a very useful thing. And if you're going to make that decision, pull the trigger early. My suggestion is do it early if you're going to do it. If you're not going to do it, don't do it. But again, if you're going to do it early. Earlier the better.
Okay. Thank you very much. And then the epidural is a very good thing in my experience, thoracic epidural for plain chest.
Absolutely. Absolutely. Great pain control by far has been shown to, the first group that did it was actually a few of my friends in Buffalo, New York, and at the Erie County Medical Center. And they clearly showed, no question, thoracic epidural for pain control is way better than anything else.
Thank you very much. And one more question is about penetrating injury on the chest. Do we remove the knife or don't remove the knife? If someone is coming with a knife.
If you have penetrating trauma, never remove an impaled object except at surgery. They have to go in, they have to identify where the penetrating object is, gain control of the anatomic structures, and then remove. Do not remove any impaled object, please. This is not a part of this topic, but penetrating trauma. But when you have penetrating trauma, do not remove the impaled object. If you have an impaled object, whether it be a rebar, whether it be a knife, whether it be anything, do not remove it, because if you remove it, then you're going to lose the tamponade effect, and that patient will be in terrible trouble. That's not a good thing to do.
Okay. Thank you very much, Dr. Chandrasekhar. Thank you.
My pleasure. Any other questions? Okay, guys. Have a good day, and we'll continue to keep moving. But remember, we have ER consultations available now. Utilize your ER consultations. Utilize, please. Any questions, please bring them in. And the other thing is by the way, we have nursing supervision capacity available. If you guys need nursing supervision to help your nurses more, please, talk to our salespeople about this. We'll get this sorted out. We'll get you more rigorously involved, and we'll get your nurses upscaled much better. So please talk to our people.
Thank you, sir. Excellent.
Thank you.
Excellent presentation. Thank you so much.